Hello everyone, welcome back to my channel. Today I want to cover the most up-to-date approach to adult asthma, straight from the Global Initiative for Asthma 2025, because it's slightly different than some of the guidelines in the past. Particularly sending the message that SABA monotherapy is no longer acceptable in most adults, short-acting beta agonist. Basically, the preferred management track is now what they call track 1, where they use low-dose ICS formoterol, is used both daily and as needed. And this approach is recommended for most patients 12 and up. So let's break down the actual updated stepwise approach for adults. Step 1 would be low-dose ICS formoterol as needed. Step 2 is the same as step 1, or you can use the low-dose daily of ICS. Step 3 is maintenance ICS formoterol with as-needed use. This is actually called SMART therapy. Step 4, you'll actually use a medium-dose ICS formoterol with SMART therapy. And step 5, you can do add-ons like LAMA, biologics, or referred to a pulmonology specialist. So now, why the shift away from short-acting beta agonists? This is because essentially using more than 3 canisters a year is now linked to a higher risk of severe exacerbations and asthma-related death. So the global initiative is now emphasizing not just medications, but also environmental exposures, inhaler technique, air quality, and device sustainability. So this is a broader systems level push. In the US, we still tend to use the NHLBI 2020, which has some overlap, but they do differ slightly. The NHLBI conditionally recommends SMART therapy for moderate to severe asthma and actually discourages chronic systemic steroids. They also say you can refer to biologics when the patient needs steroids 2 or more times a year, they've had an ICU admission, or they're steroid dependent. So now let's talk actual ICU level care if a patient comes to your door with severe exacerbation. So the first thing you want to do is start with oxygen around 93 to 95%, add continuous albuterol plus ipratropium, give them systemic steroids, IV methylpred or oral prednisone, and then you can add in IV magnesium sulfate for moderate to severe flares. You can also admit the patient to the ICU if there is impending respiratory failure, silent chest, rising CO2, or altered mental status. If intubation is required, make sure to use low respiratory rates and long expiratory times. Think of an IE ratio of 1 to 4, or even more in some cases. Accept permissive hypercapnia, keep the plateau pressures below 30, and use deep sedation, and consider paralysis if the synchrony continues. You can also consider ketamine as both a sedative and a bronchodilator. So that's about all I have for the Global Initiative for Asthma 2025 updates. It's a little different than what's on the tests, the MBME, but for sure make sure you know these guys for clinic because they have just published this. Thank you.